All right, good afternoon, everyone, and thank you so much for joining us for this month's Teach Educational Rounds. Here with us today, we have Dr. Zawertailo, who will be presenting on e-cigarette prevalence, health effects, and addiction risk. Before I hand it off to our presenters, I'm just going to go over a few housekeeping slides. If you're interested in receiving a letter of completion for today's Teach Educational Round, please make sure that you have registered for this webinar and completed the pre-learning assessment, that you have signed in to view this webinar using your first and last name so we can track your participation, and finally, you have completed the post-learning assessment, which will be emailed to you by the end of tomorrow, and you will have 1 week to complete that. Please note that a copy of today's presentation slides will be sent along with the recording this afternoon as well. This webinar is being live tweeted on Twitter, and you can follow us at PSQuitSmoking and use the hashtag TeachWebinar to post or read questions. Here's a little bit more information on our presenter today. Dr. Laurie Zawertailo obtained her PhD in pharmacology at the University of Toronto. Since 2005, Laurie has been working as a scientist at CAMH with research interests in the area of behavioral and neurobiological aspects of tobacco dependence and treatment, especially in individuals with comorbid depression or alcohol use disorders. She is currently the co-principal investigator of the STOP program, and her goal is to understand the neurobiological and behavioral processes involved in nicotine use and addiction in order to optimize treatment outcomes. You can read more about her work here. Here's a list of her disclosures, and here's information on our disclosures. Please note that the content of Teach Educational Rounds are centered on evidence-based guidelines from the following sources. These materials, as well as the verbal presentation and any discussions, represent only general principles, and they do not remove the need for clinical assessments or treatment plans by healthcare professionals. Please feel welcome to use the chat feature during today's webinar to provide any feedback or post any questions. To use the chat feature, you can click on the speech bubble icon in the control panel, and please ensure that you select everyone to make sure that the panelists and the host can read your questions. As a note, this feature was previously labeled as all participants. Finally, we will hold a brief question and answer period following the presentation. You may either save your questions until that time or type them in the chat and we will save them. With that, I will leave it to our presenter to take it away. Thank you, everyone, and enjoy the webinar.
Great. Thank you, Sophie, for that introduction. And thank you, everyone, for taking your lunch hour to spend some time talking about e-cigarettes. I know the last Teach webinar, Dr. Selby presented on what we're doing with e-cigarettes, what we know, but more from a clinical perspective. I think I'm going to take more of a, what's currently known in the research world with respect to e-cigarettes. And sorry, there, it works last time. Okay, good. So the learning objectives that were on the poster we're going to follow. So we're going to briefly talk about the current knowledge regarding health effects of e-cigarettes. We're going to discuss current trends in prevalence and characteristics of use of e-cigarettes, including assessing addiction risk and severity of addiction. And then we're going to summarize the limited emerging evidence for approaches to treatment for e-cigarette addiction. So I think before we start, just to remind everyone that, when we talk about e-cigarettes, we talk about them like they're one thing, and they're not, clearly. They've, over the last several years, have undergone a huge amount of change and development. And, what we currently see people using are mostly these fourth generation pod devices, Juul or Juul-like devices. We also see quite a bit of second generation e-cigs, so the slimmer, kind of easy to use e-cigarettes, and we're seeing, at least I'm seeing, less and less of these big tank models that are modifiable and are a kind of a niche user market, I think. So suffice it to say that, they all look different, certainly, but they also behave differently with respect to how much nicotine is in them, potentially, and how much and how effective they are at delivering that nicotine into your bloodstream and your brain. So, and I think the other thing we need to be aware of, certainly when we talk about vaping with our patients and clients, is that, vaping is a mode of drug delivery. And it can mean different things to different people. So, we may be referring to vaping as in vaping nicotine, but if you're talking to especially a high school student or a young adult, they may be vaping other things, mostly cannabis, THC. So just to be aware that when you are having this conversation with your patients, that you are all on the same page, that you're starting from the same level of understanding. So I think, with respect to combusted tobacco, e-cigarettes, I think everyone is in agreement that e-cigarettes are safer than smoking. I think the argument remains regarding how much safer. And also, we've moved away from perhaps the discussion around e-cigarettes as a harm reduction tool. I think for people who are unable or unwilling to quit smoking using evidence-based methods, that, trying an e-cigarette is a better option than continuing to smoke. However, the new, concerns certainly are among e-cig use among people who have never smoked, and what are the unique harms of e-cig use among those people. So this is data from a very large, well-done study published in JAMA in 2018. And it basically compared a group of cigarette smokers with dual users, with people who use e-cigs only, and with never users of any type of nicotine product. And they looked at levels of exposure to various components. Usually these are things that are present in combusted tobacco, and they're interested in looking at levels of exposure among these e-cigarette users compared to dual users. And basically, the main takeaway here is that dual users, so on all the graphs on the far left are the cigarette-only users, followed by the dual users, then the e-cigarette only group, and then the never users. And you can see that for all of these things, nicotine, NNK, lead, cadmium, naphthalene, pyrene, all of these awful things, acrolein, that tobacco smokers and dual users are pretty much identical. There is no decrease in risk associated with dual use of tobacco and e-cigarettes. So that's one takeaway. The other takeaway is that certainly among e-cigarette only users, they are significantly exposed to nicotine, obviously, compared to never users. With respect to lead exposure, even never smokers are exposed to lead. So, and e-cigarette users seem to be exposed to about as much lead as tobacco smokers. There's less exposure to things like pyrene, acrylamide, acrolein, and NNK. These are all kind of known carcinogens. But there are aspects of e-cigarette use that are kind of similar in a lot of ways to exposure in dual users and cigarette smokers. So, they are certainly not harmless or benign. There are components of e-cigarettes that may, down the line, prove to be quite harmful to users. So, and I think kind of what this study didn't look at is kind of things that are unique to e-cigarettes or e-cigarette vapor exposure that are not present in combusted tobacco. And so, we continuously continue to hear about the harmful effects of e-cigarettes, the dangerous toxic metals that are in either the device itself when it gets heated that people are exposed to, or the e-liquids. We hear about contaminated e-liquids. We hear about the potential toxic effects of the flavors that are used. And so, this is a continuing area of research, and the most recent data on the harmful effects of e-cigarettes are mostly related to the respiratory effects. So certainly e-cigarettes have been shown to exacerbate asthma and other respiratory illnesses. There continue to be case reports of lung injury resulting from excessive vaping, and this is beyond the kind of E-Valley epidemic, pandemic, whatever you want to call it. That was about a year ago, I guess, which most of those cases were related back to contaminated THC cartridges that contain vitamin acetate and other contaminants. And so, but even still, there continue to be case reports of this kind of lung injury, and certainly in very excessive kind of compulsive e-cigarette users. But beyond that, even among normal users, there is growing evidence that it does cause respiratory cell damage. So, and along with respect to cell toxicity, disruption of airway barriers, and that even some flavors, like cinnamon flavor, can suppress the motility of the ciliary little hairs in the bronchial epithelial cells. And all of this may increase susceptibility to viral infections. And of course, this is especially important now that we're in the middle of a pandemic. So this is all research that is being conducted at Sick Kids Hospital here in Toronto and other places that we're collaborating. We're finding e-cig users for them to brush their nasal cells and grow them and see if their cells are different than healthy controls. So this is just a schematic of all of the reported effects of vaping on the human pulmonary system. This was published in the BMJ a year and a bit ago. And you can see that it really does affect all areas of the pulmonary system and airways. What's not shown here is the effects that it also has in the mouth itself. Causes a lot of dryness and changes the oral microbiota. So it can affect dental health and oral health as well. So, the evidence continues to grow regarding the effects of e-cigarettes on all of these different systems. So certainly this is a concern, especially among youth and young adults, where the prevalence of e-cigarette use continues to rise. According to the Ontario Student Drug Use Survey, in 2015, only 2% of high school students used e-cigarettes at least weekly or daily, and this is up to 13% in 2019. And then a survey by Dave Hammond, Across Canada survey, showed that almost 30% of high school students vaped in the past 30 days, and of those, 40% of them were vaping daily. So this is and continues to be an issue. How much of an issue it is over the past year during COVID, where, like everyone else, high school students are pretty socially isolated. Not hanging out with their friends. Vaping tends to be a pretty social activity among this age group. So we'll see. I think among some, vaping will have decreased, and others because they have nothing to do and they're in their bedrooms all the time, they're vaping even more. So, you know, most of these high school students really have never smoked before, so this is a new crop of youth and young adults that have never been exposed to cigarette smoking but are now vaping. And so the concern there also is not just the health effects of an addiction risk of vaping itself, but the transition from vaping to smoking. A little unclear about how much of an issue this actually is. I'd be interested in hearing what any of you see clinically in your patient population. But certainly a recent, again, cross-Canada survey of high school students showed that not only over the years has e-cigarette use increased exponentially, smoking is also increasing among grades 10 to 12 students. So, you know, it's still really low at 3.5%, but I think, you know, we will see it continue to grow. And you know, I wonder if it's kind of what, you know, public health policy researchers were concerned about 6 or 8 years ago with the normalization of e-cigarette use, is that it would actually re-normalize smoking. And, you know, among youth where we've done such a great job at curbing smoking, you know, when I was in high school, everybody smoked. Like, this percentage would have been 70 or 80% in the high school that I went to. So to get it down that low is incredible. To see it go up again is a little bit concerning, for sure. Okay, so that's youth and young adults. What about the rest of the population? So all of you who are STOP implementers know that we collect data about e-cigarette use at baseline. And so this is just a map, a heat map of the prevalence of self-reported e-cigarette use at baseline among the STOP population. And so basically, the very light blue is very low use, very low prevalence of concurrent e-cigarette use at 3 to 8%. The darker blue is 8 to 10% prevalence, and then the very dark blue is 10 to 18%. So you can see that overall, in all of the STOP population, in 2016-2017, 9.3% reported using an e-cigarette in the past 30 days at their baseline enrollment. And you can see that the pockets of higher prevalence occur mostly around the Golden Horseshoe and southwestern Ontario, and a little bit in the Ottawa region and eastern Ontario. Very low prevalence in the north, and then a moderate amount of e-cigarette use in the rest of the province. So when we look at the 2017-2018 data, we can see a little bit of a change. There's an overall decrease in prevalence to 8.6%. And you can see that eastern Ontario, the prevalence has decreased. It's remained low in the north. And it's pretty much the same. Toronto went down a little bit. And then when you go to 2018-2019, the prevalence is pretty much the same at 8.5%, but the pattern, again, has changed. So you see, again, low prevalence in the north, but you see a change in kind of Peterborough area, and a actual increase in the Huron area compared to last year. So very low use in 2017-2018, and then the higher amount of use in 2018-2019. We haven't looked at the data yet for 2019-2020 or 2020-2021. Be interesting to see, and again, we'll be interested to see the effect of COVID on e-cigarette prevalence in our population. So in addition to asking about e-cigarette use at baseline in the STOP population, we also ask about it at 6 and 12-month follow-up. And we're interested in what effect, if any, concurrent e-cigarette use has on actual quit outcomes at 6-month follow-up. So our quit rates at 6-month follow-up are around 35% overall. And you can see that when we break it down between people who do not report using any e-cigarettes compared to people who report using them but not every day, compared to daily end users, you can see that there's differences in their quit rates. So with respect to using ends or e-cigarettes non-daily, this seems to have a huge impact on the ability for people to quit and be quit at 6 months follow-up. There seems to be also some effective daily e-cigarette use, but when we control for, statistically control for variables that we know are associated with the ability to quit smoking, like one's age, gender, the presence of medical or psychiatric comorbidities, concurrent drug use and alcohol use, and socioeconomic variables like income, education, and employment, we can see that, and this is the adjusted values here, that there's no longer an effect of daily end use on quit. They're as able to quit as people who do not use e-cigarettes, but there is no improvement of their quit outcome. It's the people that are using non-daily that continue to have about a 60% decrease in their ability to quit smoking. Why this is, we're not entirely sure. Requires a little bit more investigation, but one thing we thought was, well, maybe they're not using very much NRT, and that's why they're not able to quit. But when you look at the amount of NRT, the total amount of NRT that was dispensed over a 6-month period in each of these groups, you can see that among the people who were quit at 6 months, non-daily end users did use even a little bit more NRT than the non-end users. So if they were non-daily end users, but they were given sufficient amounts of NRT, they were able to quit. It's the daily end users that didn't use very much NRT at all, but were still able to quit. So this is interesting, and I imagine it is just that they're using their e-cigarette as a form of nicotine replacement therapy, so they're not needing as much nicotine replacement therapy from stop as successful quitters in the other groups. Now, when we look at these people who are not quit at 6 months, all of them don't use very much NRT, but certainly the end users use significantly less than even the non-end users. And so we were interested in, what is it with these people and what happens to them at 12 months? Do they have any difference in their quit outcomes at 12 months? Are they able to quit later on? And you can see here that they are able to quit, but in differing, they have different success rates at this. So if you're a non-end user at 12 months, so this is pretty much after you've exhausted your supply of NRT, we get an additional 7% of non-end users that are able to, that report being quit at 12 months. So they've either maybe purchased their own NRT, they've tried another method, but we get an additional 7%. Non-daily end users still really don't have very high quit rates at less than 5%, but people who continue to use their e-cigarette daily at 12 months, we get 20% of those people report being quit at 12 months follow-up. And so again, when we adjust for variables that we know are associated with successfully quitting smoking, you can see that the odds of quitting smoking is 3 times higher in people who are using e-cigarettes daily compared to the people who are not using e-cigarettes at all. So this is interesting. It's a little bit similar to what the big clinical trial that was published a couple years ago in the New England Journal showed that e-cigarettes were better at the nicotine patch at getting people to quit smoking, but at the 1 year time point, they still had a lot of people who were quit smoking, but most of the people in the e-cigarette group were still using their e-cigarette. And, you know, we can argue about whether this is a concern or not. You know, it is harm reduction. Are we now worried or, you know, have they just exchanged one addiction for another? And do we have to worry about them being addicted or dependent on their e-cigarette? And regardless if we're worried, if they're worried, what do we do about it? So, you know, this brings us to the issue of, you know, the addictive potential of e-cigarettes and, you know, that potential compared to traditional tobacco cigarettes. So, you know, all addiction is based on how the drug of interest acts on the brain, and specifically this brain reward system. So I think this audience knows that nicotine acts by entering the brain, stimulating nicotinic acetylcholine receptors, which in turn release dopamine, and they release dopamine in this brain reward system of the brain, the ventral tegmental area and the nucleus accumbens. And this in turn sends signals up to the prefrontal cortex, telling your higher brain, that was good. I liked that. Remember this, learn it, because I'm probably going to want to do it again and again and again. So this is the way drugs work. One of the most important aspects of whether a drug will become addictive is how quickly this effect happens after the drug is administered. So the method of drug delivery is very important. Smoking, any drug, is the most effective way to deliver the drug quickly and effectively and at high concentrations into the brain. Whether vaping is similar, again, is something that continues to be researched, but there is evidence that it's probably pretty similar. So in addition to all of this physiological effect, the self-perception of addiction, so people self-reporting that they're feeling a loss of control, they're feeling cravings to use, and their experience withdrawal symptoms are really the most important way that we have as clinicians or researchers to determine whether someone is addicted to a drug or not. So when we look at and compare e-cigarettes to cigarettes with respect to how quickly the drug, in this case nicotine, gets into the brain, is to look at pharmacokinetics. And so this was a study recently published in Drug and Alcohol Dependence. And the black dotted line is the participant's usual brand of cigarettes. So they smoke a cigarette, they get blood samples taken regularly over this time period from 0 to 120 minutes, and then plasma nicotine levels are measured and plotted. So the plasma level of nicotine is a good proxy measure of the amount of nicotine in your brain, and this time course is a proxy measure of the kinetics in your brain as well. So you can see that when a smoker, and these are all smoker participants, there was 65 of them, when they smoke, their blood nicotine level rises very quickly. It reaches a peak concentration in about 2 to 4 minutes, and then it slowly decreases over time. This was a study that looked at Juul e-cigarettes and compared them to a comparator e-cigarette, which was the Vuse e-cigarette. And so they looked at all different flavors of Juul, but they looked at only the single dose, the 59 milligram, the high dose. So you can see here that flavor doesn't really matter, that all of these smokers used the Juul in pretty much the same way, reached a peak concentration of nicotine at about the same time as they did with the cigarette, but a lower concentration. And then the descending curve looks about the same as it does for the cigarette. The only flavor that didn't quite reach the peak of the other flavors was the creme brulee flavor. I guess they just didn't like it. But the other ones, mango, mint, and tobacco, Virginia tobacco, all look the same. And then in the red dashed line is the comparator e-cigarette, so a little bit lower. And then on the gray, the very light gray here, I don't know if you can see it, but that is kind of their negative control, which is nicotine gum. So you can see here that the kinetics of nicotine gum is a lot different. It's a very slow onset. It doesn't reach a peak until 30 minutes or so, and then that peak is kind of sustained over the full 120 minutes. So this is why nicotine gum is not highly abused or doesn't have a high addiction potential, because it does take so long to reach peak. That's not to say that some people don't feel like they become dependent on nicotine gum, but it happens quite rarely. So, and these are the subjective effects. So again, these are all the Juul flavors. The white bar is the nicotine gum. The dashed red, striped red bar is the other e-cigarette, and the dark gray bar is the cigarette. So cigarette smokers like their cigarette the best on all measures, but they also like the e-cigarette, and they seem to like the mint flavor pretty much consistently more mint or mango than the other flavors. And the nicotine gum has the lowest ratings on all of these scales. And so the scales are, I like it, I intend to use it again, I found it satisfying, I would like more of it, etc. So these are all just kind of measures, traditional measures of drug abuse liability. So, you know, that's a lab study. We're not going to do that with everyone that we see. So how can we assess dependence on e-cigarettes in our patient population or participants that we see? And so, you know, currently, everything that is in the literature is basically using questionnaires to assess tobacco dependence and just subbing in e-cigarette or vaping for smoking or cigarette. And so this doesn't have great validity. There's lots of things about e-cigarettes that are different than from smoking. And it just really doesn't make a whole lot of sense. So, you know, this is the e-cigarette version of the FibroStorm test for nicotine dependence, and I know a lot of you are familiar with it. How many times do you use your e-cigarette? Okay, that's probably fine. How soon after waking up do you use your e-cigarette? That's probably fine. Do you find it difficult to refrain from vaping in places where you're not supposed to? We know, especially with Juul devices, that they can hide it. It's really easy to just continue to vape wherever they want. Which e-cigarette would you hate to give up? That doesn't make a whole lot of sense. Using your e-cigarette more frequently in the morning, again, that's pretty okay, I guess. And vaping even if you're sick in bed most of the day. And so, you know, the FTND, even though it is the gold standard and the one that most people use to assess e-cigarette dependence, it doesn't have, it's never actually been tested for validity. And, you know, most studies have shown that it's really just the first two questions that determine level of dependence. So how many cigarettes you smoke per day and how soon after waking up do you smoke? Those are the two ones that are the most predictive. It remains to be seen if they are also the most predictive with respect to e-cigarettes. So, you know, we wanted to develop a questionnaire that was validated and got at more kind of constructs of e-cigarette use than the eFTND. So we came up with 28 questions that were they weren't questions that we made up. They were questions from all of these different e-cigarette tools that got at different aspects of vaping, including positive reasons. So perceived benefits, vaping helps me think better, helps me feel better if I'm feeling down. I enjoy the feeling of inhaling vapor. I like the smell. I like creating vapor clouds, etc. And we put this questionnaire out. We compared it to the EFTND, and we did this study on Amazon MTurk, which is basically a crowdsourcing kind of survey software. We could specifically recruit the subject population that we wanted. So we wanted e-cigarette users. We wanted both people who were exclusive users and dual users. And we also recruited a group of controls for this experiment. So you can see that exclusive e-cig users, about a little over, actually the vast majority of them were former smokers. Only 6% were never smokers. And most of them use their e-cigarette daily. And among the dual users, most of them, just slightly over half, actually smoke daily, but most of them use their e-cigarette daily. When we asked about self-rated or self-perceived addiction to their e-cigarette, it was pretty much the same between dual users and exclusive e-cig users. It wasn't statistically significantly different. And their EFTND score was also a little bit higher in exclusive users compared to dual users. So when we got all of these people to answer the 28 questions, we actually were able to pare it down using validated methods to 15 questions that seem to have the most validity. And they mapped onto two different factors. So the first factor was how the impact of ends on their lifestyle and their ability to do other things. And the other factor was looking at both positive and negative reinforcing effects of their e-cigarettes. So perceived benefits and then relief of negative feelings like withdrawal, etc. So we have 15 questions. They all seem to be highly correlated with both self-rated dependence or addiction and amount of use. We're also interested because everyone seems to be of the opinion that dual e-cigarettes are more addictive than any others. And you can see that our questionnaire, which we call the NSDQ, is more sensitive in this respect. So people who are primarily using a dual or dual-like device reported significantly higher ratings on this questionnaire. And the EFTND was not at all sensitive to this difference. In fact, people who did not use a dual-like device scored higher on the EFTND. So we think that, because we're getting at some different constructs, that perhaps our questionnaire is more sensitive. Okay, so, now we have tools to assess e-cigarette addiction and dependence. What do we do with people when they are perhaps treatment seeking, they're interested in reducing or stopping their e-cigarettes? How do we help them? And this is this is a challenge. And I think, certainly what is currently out there is focused exclusively on youth and young adults. These are all kind of online initiatives. So there's the Truth Initiative out of the U.S., which is an online text messaging support program for youth and young adults that want to quit vaping. A similar one from California. I'm sorry, I don't know much about the Muskoka one. Maybe there's someone on the webinar that can talk about it. That'd be great. And then the Lung Health Foundation has started a QUASH program, which again is focused on youth and young adults interested in reducing or quitting vaping. I know that the Ontario Tobacco Research Unit is very interested in youth and young adults vaping and vaping cessation, and they're also developing a program that is based on a series of focus groups that they ran and published recently in addictive behaviors. So all of this to say is that there are currently no interventions that I know of that are for adult or dual users. There is, I think, in Vancouver, there is a clinical program that is using NRT, but I don't know if it's been kind of systematically protocolized or if it's just something that's happening in the clinic. So currently no published evidence base for using pharmacological interventions for e-cigarette cessation either. So that brings us to what we are going to be launching very soon. We're calling it E-Squared, E-Interventions for E-Cigarettes. It's going to be part of our Stop on the Net program, which is just a online, you enroll, you consent online, and we mail you 4 weeks of NRT. And we're going to, when we ask about baseline e-cigarette use, which we do for everybody, those who report past 30-day e-cigarette use and also report perhaps being interested in a program to help them reduce or stop their e-cigarette use, they will be offered this online self-paced CBT program that Teach is developing. And it contains 5 modules that they can do on their own, usually 1 a week. And it will focus on using CBT strategies to reduce or stop people's e-cigarette use, whatever their goals are. So we'll be launching this soon, I hope. It's just going through ethics, and we'll see. You know, it's mostly to test just the feasibility. Are people interested in this? Are dual users interested in stopping their e-cigarette use, or are they happy to continue using their e-cigarette and just focus on quitting smoking? And then, you know, we'll move on from there. We're very interested in this area of e-cigarette research and e-cigarette cessation. So stay tuned. So I think that is my last slide. It is. Thanks for listening. I want to thank my students that helped with a lot of this, and all of our team of statisticians that do all of the STOP data management and analysis. And yeah, happy to take any questions.
So Laurie, I'll just send you along some of the questions that popped up during your presentation, all right?
Am I supposed to see them, Sophie?
They should just be there in your private chat. You might just have to open up the chat box on the bottom right hand. No worries.
Curious about using cannabis in vapes compared to nicotine use, if there's a difference. I'm not sure what you mean. A difference in what way? anyway, perhaps if you can clarify. So yes, Carolyn McIntosh asked if there's no difference between dual use and cig only, even if they've reduced their cig consumption. So yeah, and I mean, that's one limitation of that study. I don't think they asked a lot about, how much they were smoking versus using their e-cigarette. You would think intuitively that if they've significantly reduced their cigarette consumption, that there should be some reduction in exposure. But yeah, it wasn't evident in that paper, and it also wasn't evident from the way they presented the data. If you noticed, kind of they had the bars, and then they had those big whiskers, which means that there's huge variation. So I'm sure there are some people that did have a significant reduction compared to exclusive smokers, but it was difficult to tell from the way they presented that data. What is chronic vaping? I'm sorry, did I use that term? I mean daily. Daily. If you're asking because someone else has used that term, it could mean anything. Chronic to me might mean kind of excessive, that kind of grazing behavior that you hear about, where people are just constantly have their device in their hand, and they're just, they don't have a discrete session. They're just using constantly. How does vaping e-cigarettes compared to smoking a bong? Again, I'm not sure. Do you mean like a hookah? Or to me, a bong means like smoking hash or cannabis. Yeah, and a bong is like a water pipe, so it's different because it's smoke, but it's just cooled through the water, so it doesn't feel as harsh, but it is still smoke, whereas vaping is not smoke, it's vapor. Did any of the quit studies with vaping look at quitting nicotine or just smoking? So you mean the studies using e-cigarettes to quit smoking? Are they looking at quitting nicotine? So there are some studies that have compared a placebo e-cigarette with a nicotine e-cigarette. And there's some evidence in some people that a placebo e-cigarette is as effective as a nicotine e-cigarette. So in those people, it's perhaps not the nicotine that they're, that they're just as addicted to the behavior, the hand-to-mouth action, et cetera, as they are to the nicotine. Can you comment on the study mentioned that those who use e-cigarettes daily have quit but still continue to use their e-cigarette? There's still several carcinogens. Yeah. So, yeah. So, I mean, this is Rachel's question. Can you comment on the study that that use e-cigarettes daily, they've quit smoking, but they're still using their e-cigarettes daily? If there's still several carcinogens that are being inhaled, is it truly harm reduction? And again, this is the current debate, right? Like how much safer do they have to be than cigarettes to be truly considered harm reduction? And I think, this is something that we're just going to have to wait and see. I think, certainly carcinogen exposure is lower. I think we can say that. It's these other things that are, we don't know what their carcinogenic risk is, but we know that they are harmful, especially to respiratory health. But I think it's pretty safe to say that if you switch to e-cigarettes, your cancer risk is most likely reduced. Thank you for all the questions. These are great. Slide on pharmacokinetics seems to show e-cigarettes would be less addictive than combustible. Okay, right. I think I forgot to mention this. So in that study, everyone that participated in that study were cigarette smokers who had never used an e-cigarette or a Juul device. So this was their first time using those type of devices. And so, it's reasonable to expect that they're not using them as effectively as they could. There have been other studies in experienced users that have shown, especially Juul, that they can far overshoot even the peak concentration that's reached with smokers. So I should have shown that data as well. But in experienced e-cig users, they can easily reach the peak concentration that smokers reach with respect to plasma nicotine levels. In the Golderson study, vapes had approximately half because, So I think I answered that question. Let me know if I didn't. I agree with respect, if you are going to kind of go off label and use NRT to help people come off e-cigarettes, I agree that you should start with a low, a low dose patch and maybe a short acting and just ask them to titrate and see how it is. I don't think, because we really don't know. People's behavior is so different, the types of device that they use and the amount of nicotine that they're able to extract is so different that, apart from taking a plasma or urine nicotine level and trying to match it, I really don't know how else you would attempt to dose with respect to using MRT. Are the different forms available in a PDF? I can send you if you're interested in using the NSDQ and the other e-cigarette questionnaires. I can send those to you. On the interactions with the drugs from medical use. Do you mean the interactions with respect to nicotine on drugs? So that's a big question. So, we know that nicotine can induce different enzymes that are responsible for metabolizing certain drugs, and that can affect both the plasma levels reached of those drugs and therefore their effectiveness. But it's hard for me to comment on whether or not the specific drug you're interested in would be affected by using nicotine. Yeah, so everyone wants to know how do you dose NRT with respect to e-cigarette use, and there is no nothing that has been looked at systematically to attempt to do that. Like I said before, I think starting low and working up is probably your safest and best bet. And I also want to say that maybe NRT isn't appropriate. I think, especially for people who were never smokers, perhaps using just behavioral methods to start with is the safest. And I think that's why all of these programs are focused on just behavioral support, CBT strategies, et cetera. There was something else I was going to say. Oh, there is quite a bit of evidence that, sorry, code call. I'm just going to mute myself for a second. Okay, so there is evidence that the level of nicotine dependence on e-cigarettes or addiction is actually lower than on cigarettes. So, behavioral interventions alone may be effective, and I think those perhaps need to be explored before automatically going for the NRT. E-squared program up to other provinces. We would love to do that, but I think we need to test and show that it's feasible in Ontario first. Stay tuned. Pulmonary diagnostics, quantified tobacco counts, vaping for interpreting specialist tobacco is condensed, pack year smoking. Yeah, I agree. I think we need that measure, that kind of overall exposure measure for e-cigarettes, similar to pack years. I'm not sure how. I think certainly in people who do use the Juul-like or pod devices, it might be easier because it's easy for them to quantify, how many pods they go through in a week, or and then how long they've been using. And I think you will be able to get that sort of pack year for those users. It's the other ones where it's so variable that it might be difficult to do. Those who have quit smoking but continue to use their e-cigarettes. Yeah. Sounds like you will be giving NRT to e-cig users in your e-squared program. Right. So because it's part of STOP, and people are signing up for the program to get NRT to help them quit smoking, that's what the NRT will be used for mostly. We are hoping, that it will also help them curb their e-cigarette use if they're interested in doing that in conjunction with using our online CBT program. But we determine the amount of NRT that we are mailing out to them based on their cigarettes per day. And we're not taking into account their level of e-cigarette use at all. Why do you think the prevalence of use has changed so much, especially in the eastern part? I would love to be able to answer that question. I don't know. A lot of it could just be natural variation year over year. I don't know. Some of it could be, especially in these smaller areas, that someone opened up a vape shop and everyone decided to go to the vape shop and see what it's all about. I honestly, it's your guess is as good as mine. With the data we have, it's really hard to determine that. Zawertailo, it would be less effective. Yeah, sex differences. So there are potential sex differences. In our MTRIC study, where we had a large enough sample to look at this, females did seem to be to have slightly lower scores on the dependence questionnaire compared to males. But again, this is research that's in its infancy. We're certainly interested in that gender effect and in other research that we're doing, but I won't bore you with those details.
All right. Laurie, I'm just wary of time,
Okay.
But I just want to let everyone know that our next Teach Educational rounds will actually be March 24th, 2021. And what that will be is a full hour Q&A panel kind of session with Dr. Selby and Dr. Zawertailo. So what we'll be doing is gathering questions from the last webinars as well as any unanswered questions from this one. And we'll have an opportunity for any of you to submit any questions that you may have ahead of that. So I know that we're pressed for time today, but I just want to ensure everyone that we will be providing that time as well. And then I just want to really sincerely thank you, everyone, for attending today's session. And thank you so much, Laurie, for such a lovely presentation. Just a reminder that if you missed a portion of today's webinar or if you're interested in viewing again, it will be posted to our Teach YouTube channel, and we will be distributing a copy of the presentation slides as well as a link to the recording and any resources that may be helpful following the session. So I hope you all enjoyed, and I wish you a lovely rest of your afternoon.
Thanks, everyone.
Thanks so much.